Now our subsequent speaker is a counseling psychologist at Reem in neuroscience, working closely with children and teenagers and utilizing psychoeducational assessment as part of his practice. Please join me in welcoming Mr. Frederick William.
So today I'll be speaking about autism, facts, myths, and errors in diagnosis. So one of the myths is that all autism looks the same. If you see one child with autism, you know another child. But the truth is that there's so many differences when it comes to autism. And that is why sometimes we make a mistake in diagnosing autism. For example, a clinician sees a young child for 10 minutes in his office, looks at the child and sees, oh, this child has great eye contact. No autism, because all autism kids have bad eye contact. Of course, this is wrong. Poor eye contact is one of the symptoms that we can see in the autistic child. So the DMS-5 says there must be two things present in order to do a diagnosis or make a diagnosis of autism. The first is social communication, and yes, it often involves speech, but it's also relating with other people. For example, sometimes we have children who have great speech ability, but they speak in the air. And that would be part of the reciprocity between you and the child. So one of the facts for older people, for teenagers and for adults, is sometimes they don't understand social boundaries. They stand too close, or if a conversation is finished, maybe you know many of your colleagues like this, you're showing them the conversation is finished, you turn around to walk, but they just keep on talking. So they don't see the social cue. Sometimes one component of social communication is they don't understand humor or symbology. The second part of the autism requirement is there must be restricted interest or an insistency on sameness. Every day the dad drives to the Bakala, and after the Bakala we go to Madrasa. But if dad didn't stop at the Bakala today, then there's a big tantrum. So it's an insistency on sameness. Another thing is that they might have an interest in elevators, opening the door and close the door. So my sister, she has a holiday farm in South Africa, and I like to see the kids, and there's kids that open the door and close the door. And of course, Dad thinks it's very cute. We only think it's cute for a few months because every time you have to open and close the door. But of course, that could be one of the signs that there is autism. And sometimes there's a sensitivity to sounds, to labels in the clothes. And this is the second part of the autism requirement. So should the child have poor speech, but there's no hand movements, or there's no insistency of sameness, there's no restricted repetitive patterns, then probably it's not autism. So the DSM-5 says it must be present from early childhood. A child is not non-autistic at 5, and after 5 becomes autistic. So there's a sooner or earlier diagnosis. And it doesn't account for global developmental delay or intellectual disability. So, error. My child has great speech ability, so therefore no autism. I often sit with parents in the office and I say, tell me about your child's speech. No, my child is amazing. He is so good in speech. He can tell you the exact words of a movie. Frozen. Everything in the movie Frozen is repeated over and over. But when you sit with the child in an assessment space or time, then you would see lots of what is said has no context. There's no connection. For example, she would repeat things just in the air. I had a child the other day in my office, typical autistic, although in the end she didn't test autistic, but she would say, okay, children, let's count 1 to 10. And then she would go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So yes, sometimes a child might have great speech ability, but if there's no reciprocity and if there's no useful use of this speech, then that could point towards autism. So I think I just did this point. A child would sometimes say, okay, bye, see you later, alligator. And you're just talking. They would, for example, yesterday I sat with a child and she would speak and says, okay, time to go home now. We're doing an IQ test, and after a while, okay, time to go home now. And so a neurotypical child would probably say, hi, can I go home? I'm tired, we are finished, but it's kind of in the air, a speech that she's repeating. Echolalia is one of the symptoms, or one of the things we see in children. We would ask them, do you want juice or water? Then they would say water. Then you would say, would you want water or juice? They would say juice. So echolalia, often we find children with the younger children who are still learning speech, they would get the pronouns wrong. You and me and you, they often confuse those. Oh, you guys probably know more about the causes of autism. I think one of the myths is there's one causal factor, while the truth is there's many factors. I think we can all read becoming pregnant after 35, becoming pregnant within 12 months of having another child, bleeding during pregnancy, using certain medications, smaller fetal size, giving birth early, mother's antibodies fighting infection, maternal diabetes, pesticides, metals, contaminants. How many of us have sat in our office and the parents say, my child was okay before the vaccination, and after the vaccination, she became autistic. So many parents are saying that. There has been no research that proves that's the case. Maybe, I don't know, some of our sensitive children have stronger reaction. So when we come to autism, the diagnosis of it, there are a few tools. For example, as a young clinician, I use the CARS. So the CARS is a kind of a questionnaire, interview-based assessment where you ask the parents, how's the speech? When did she start speaking? At what age? And then so we ask these questions. Is there repetitive movements? And of course, you and I know if you want your child not to be autistic, it's so easy to answer these questions in a positive way and to hide it a little bit. Obviously, sometimes parents say, my child is so intelligent, they say all these things and they are brilliant at words, so they are not autistic. But as we said, that is often not the case. So there's tests like the DESCO, the ADRR, but the gold standard is the ADOS-2. So the ADOS-2, for those of us who don't know it, is a play-based test where the child, depending on their age and their speech level, they play with you and you play with them. For example, one of the activities in the younger child is to call their name, to say Salem, and Salem just keeps playing, Salem, and Salem just keeps playing. So after 4 times, the mother have to call the child, and they would then do some things like whatever, and if the child still doesn't answer you, you know that the child get a score in that area. So the ADOS is looking, how does the child communicate with the parent? How does he communicate with you? The ADOS is looking for, is the child pointing? Is he asking? Is he showing, Mama, look, there's a teddy bear. I had a child the other day in my office, and the child was thirsty. So I think the child managed to ask juice, and then the mom had the juice in her hand, and she's sitting. And Mama says, what must I do? And the child just sits. So a neurotypical child would say, a healthy child would say, Mama, can you open the juice for me? Mama, I hear it, please do it for me. I need help. But the child is just waiting and not asking or initiating. So the ADOS is designed for the younger child as well towards an adult. There are about 4 models. I think I have some of it here on paper. So there are 4 models, depending on how young the child is, but also how good the speech is. Is it single words? Is it phrases? Is it full sentences? So for example, one of the tasks is having a baby birthday. So we have the baby there, he can open his eyes, and we would put Play-Doh there, we put candles on it, and then we would sing happy birthday. So we all feel very grown up when we do it as psychologists. Here we are singing happy birthday with a 3-year-old. But depending on how the child then interacts, you pretend to spill the water or spill the juice, and if the child just sits there and doesn't react, then you can see how the child is performing in that area. So for the older children and for adults, there's lots of questions about relationships, about their future, about how do they feel lonely. Often with teenagers who look very normal, they have learned very well to adjust in situations. We would ask them, have you ever been bullied? And they would say, yes, I've been bullied many times. Then you ask them, do you know of other people that have been bullied? No, I don't. And of course, that speaks about them being here and not out there and seeing some of what happens to their friends. So I want to give you an example of what happened to one of my colleagues. As you know, that most of our prisons are full of undiagnosed autistic and ADHD children. They've missed the whole diagnosis thing. They need stimulation. They don't connect with people. So obviously, many of them land in the prison system. And one of our colleagues was sitting with a patient who was in prison. He had to do an assessment. Many people tried to do an assessment, and just once he asked something, and he said to the guy said no, and then the boys or the young man said, our doctor said, that's not your cup of tea, is it? And the person says, oh no, I don't drink tea, I drink coffee. And that immediately let the clinician say, wait, hang on a second, he didn't understand this idiom. So that is often the case for an autistic person. And they explored that, and it turned out that this person was autistic. So here's a myth: medication can heal autism. If that was the case, wouldn't it be wonderful? I think lots of our ABA therapists and our speech therapists and our OTs would be happy if we could drink a pill. We can only treat some of the side effects that we get with autism, maybe hyperactivity, maybe some of the aggression, maybe some of the sleep problems. Treatment. My child will never, with autism, will never fit in and manage socially. This is often a case of parents. I had parents in my office who cry when they hear that their child is autistic. And they think it's the end, they think it's a sentence, but I have also seen, because we worked a lot with children with autism, when they come in early, when they are diagnosed at an early age, when they get the speech, the OT, the ABA, after 2 to 3 years, if it's diagnosed early and our children have some form of intelligence, they can really adjust very well. I'll give you a small example of this little boy. He came into my office when he was 3. He often played with the alphabet. And of course, we impressed with him because he can write cat, he can write bark, he can write tree, he can write even bigger words, 5 letters and 6 letters. But the kid was highly autistic because he couldn't connect, he couldn't play. But with lots of work from the OT and the speech, and then the work that I did, I saw him a year ago when he was 9 years old. The child is like, Frederick, today at school was fantastic. The teachers was just so angry with me because I moved a lot. But otherwise it was amazing. And I'm like, oh wow, that's so good to see. So our children can manage to fit in socially, and they can grow. As said, you probably know it, speech therapy is vital for those young kids. OT, ABA is good for behavior, especially for the stimming behaviors. When a child has vocal stereotypical speech, I don't know, we've seen some patients together where a kid would just sing all the songs. And it's amazing, this kid would sing a song, and that song would be relating to what he's doing. For example, he would say, he would feel hungry and he would sing a song about eating hamburgers and pies and stuff. That was his stimming kind of behavior. So for that, we need ABA therapy. But I want to tell you about the Stanley Greenspan approach, which is called DIR floor time. DIR floor time, for me, is the right brain therapeutic methodology as opposed to ABA, which is more a left brain methodology. So I would sit with a child on the floor, and we would put toys there, and whatever he plays with, I play with him. I find that teachers are here, and the kid is there. They teach there, and the kid is here. But if you go down to their level, just a little bit above, that's when they will start to grow. So Stanley Greenspan says no learning can happen if there's no engagement. It's the number one element for a child to learn is to connect with you. And I think it's my biggest tool as clinician. I have some shortcomings. We're all aware of our shortcomings as clinicians, but one of them is to connect, and to connect with them, and obviously the deeper we connect with who they are, the greater they will connect and they will grow. So we sit on the floor. I'll use an example. I had a kid, the teacher sent him to me and says, please, can you make this kid stop speaking about sharks? He talks sharks, he eats sharks, he drinks sharks, he sleeps sharks. Whenever he's busy in life, it's all about sharks. Can you please make him stop? Of course, ABA say, let's extinct that behavior. Let's remove. I had some speech therapists says, please do not have any sharks in your room. I'm like, no, I'm so sorry. That's not the way I work. So we started with sharks. I had lots of sharks in my office, and he played with the sharks in the sand, and he made them jump, and he talked, and he sang the song, you know, that famous song. He sang it over and over. And then I would introduce a dolphin. I say, hey, I'm a dolphin, can I join you? I look a little bit like you, but not completely. No. Okay, so we go back to sharks. We played sharks, we ate sharks, I brought in some more dolphins, and then after a few sessions, the dolphins were taken in, and then the starfish were taken in, then the lobsters were taken in, and then we brought in other animals, and then we brought in people, and then finally, one day we got the teacher and the parent to say, thank you so much, my boy is now not only speaking sharks. But where did I start? I started where he was. And I would say, oh, the shark is eating that other shark. He's angry. Now he heard eating, angry, and the other. He heard those words. Here comes the red bus. It's crashing into the yellow car. And the yellow car is going to the hospital. So that's speech in context, whereas sometimes a speech therapist would say red car, say red car. So we use speech then while we play with the child. We use imagination. For me as a clinician, I think imagination opens up the child. I know my time is almost finished. I know I once had a child, he was with ABA so long, he would come in my office and he would sit and look at the toys. And I would say, we can play, go ahead. And he just looks. And he was waiting for me to give him an instruction. He had no agency within him to move. But after a while, he realized if nothing happens, I better make something happen. And then he started to play, and he saw that it was good enough. And then we worked with that. So the prognosis in children with high intellect is greater. We see the less growth when the child is intellectually disabled. Of course, these two go together, right? So if a child is smart, they can so mask it because they watch and they learn fast. So that's why sometimes we miss these intelligent children. We don't always see that they're autistic. And that's my talk. Thank you for listening.